welcome everyone to In Conversation with Dr. Cara Osborne. I'm Robin Atkinson, the CEO of Arkansas Arts and Fashion Forum. We are a nonprofit based in Northwest Arkansas, focused on incubating the fashion industry in Arkansas. However, since the beginning of COVID, we have also taken on a series of community educational programs, just sort of talking our audience through all things to do with surviving the ups and downs of the last few months. So I am very excited to be joined this evening with Dr. Cara Osborne. She is a certified nurse midwife by clinical training and holds a BA in biology from Transylvania University, an MSN in midwifery from the Vanderbilt School of Nursing, and an MS and SD in maternal and child health from the Harvard School of Public Health. Her academic area of interest is perinatal epidemiology. Cara was an assistant professor in the Eleanor Mann School of Nursing at the University of Arkansas prior to joining the founding team of a network of private equity-backed freestanding birth centers in Arkansas, North Carolina, Tennessee, and Colorado. I feel like that topic in and of itself is its own In Conversation event we should do someday. Maybe when we aren't focusing mostly on pandemic topics. In 2018, Dr. Osborne returned to the nursing school and in the fall of 2020 joined the Strategy, Entrepreneurship, and Venture Innovation Department at the Walton College of Business at the University of Arkansas, where she'll be teaching in the new venture development program and providing healthcare industry expertise to various initiatives within the college and the broader Northwest Arkansas community. She was recently added to the 2020 class of women in business by the Northwest Arkansas Business Journal and currently is a rotorcraft student and member of Summit Aviation Board of Directors at the Thaden Field in Bentonville. Welcome, Dr. Osborne. Thank you so much for joining us.
Happy to be here. That doesn't sound like anybody I know, but...
So for everybody who's watching on Facebook or who's watching here on Zoom, rules of the chat are, if you have questions for Dr. Osborne, type them in the comment section on Facebook or in the private chat to Rachel Woody Pumford on Zoom, and we will loop them into our question list. It's just easier for us to filter them on the back end. So Dr. Osborne, let's just jump in. For the last several months, AAFF has been promoting mask wearing. We jumped in early and hard on mask wearing. But we also understand that everybody's really tired of wearing them. Can you talk to us a little bit about why we should still be wearing them, situations in which it's most important to be wearing them, and then, you know, in the beginning, it seemed like maybe the science was blurry on whether or not they are effective. Where do we stand now on the efficacy of the masks?
Sure. So a couple of things. The mask wearing effort has to continue. It's really our only useful tool on a population level at the moment, given that we don't have a vaccine or treatment. So I'm tired of wearing a mask too, but we all need to wear them. And the sort of shift in rhetoric came around understanding that the reason to wear a mask had very little to do with protecting yourself and instead had a lot to do with protecting others. So masks are typically worn in a clinical setting to protect the person wearing the mask from a patient. And because coronavirus is a very small RNA-based virus, a mask doesn't filter out the virus necessarily. What it does do, though, is provide source control. So me wearing a mask protects you, you wearing a mask protects me actually quite well, because the virus is expelled mostly in droplet form as people breathe and talk and sneeze. And so having a mask on prevents that release into the air in the first place. And in terms of when it's most important to wear a mask when you're going to be in close proximity for an extended period of time. That said, it's never a bad idea to wear a mask, but If you're, by yourself in your car, you don't necessarily need to wear a mask. If you are, sitting next to someone in a car, particularly someone that doesn't live in your household, you should.
Let me ask you about kinds of masks. Have we landed on a mask that we prefer? Is there a better, best, bad, better, best? I don't know, the rating system.
Honestly, the best mask is the one that you'll wear.
Yep, there you go.
If you get down to, especially in terms of cloth masks, is this one better or is this one better? The broader point is that you're wearing something that can contain droplets. And certainly, a medical grade N95 mask contains droplets more effectively, but at that point, you're talking about sort of error around the margin rather than just, am I controlling it at all, or am I freely expelling droplets as I breathe and talk and sneeze and cough? And, I think it's important to sort of say that that's why there were some early outbreaks among groups of people singing, choirs, or people in a church who were singing, is because you forcefully expel air to sing, and of course would be near someone else in that context.
In the beginning, we gave some advice to people that you should, when going out with a mask, you should really put the mask on, leave the mask on, take it off when you get home. Where do we sit now in terms of, that was when we were sort of thinking more about surface spread and like contamination of particles on the outside of the mask, getting on your hands and then getting in your eyeballs. Where do we stand now? Like if I put a mask on when I leave the house and I get in my car, can I take it off and then put it back on? What's best practice?
In an ideal world, the least amount of touching your face possible. That said, every time you take a mask off and put it down on something, you're essentially contaminating both the mask with whatever you put it down on and also the air with whatever was inside your mask. So certainly it is still best practice to put it on, leave it on, and when you're ready to take it off, put it in the wash. That said, we all have to be realistic about what we can tolerate. And so, do your best. And again, it's most important when you're in close physical proximity to someone that's not a member of your household.
So a few weeks ago, Dr. Fauci suggested perhaps we start wearing goggles. Can you speak to goggles a little bit? I don't know that I'm ready for fashion goggles, but I can get there if I need to.
That all came up in response to talking about sort of what the portals of entry for infection could be, and certainly your eye could be. And if you were in the context where you were with someone who was quite ill, who was actively expelling particles and droplets, and you were the person, feeding or bathing them or taking care of them, would goggles make sense? Or at least glasses, splash guard, protection of your eyes. Yes. Does everyone need to wear goggles walking down the street? Probably not. Transmission of any virus is pretty clearly in direct physical contact and proximity. And so, it certainly wouldn't hurt anything. It's not like wearing goggles would make you more likely. And it is a risk mitigation strategy. It is one more thing that you can do. And it's not, it doesn't come with any real downside. So for example, I've mostly been wearing my glasses instead of my contacts so that I'm not touching whatever and then touching my contact, touching my eye. But I also am not going out of my way to wear, a closed goggle.
Okay, so sunglasses then.
Right.
Maybe the bigger the better.
Right.
So, in the beginning, we really advocated for people to go home and stay home as the sort of best mitigation strategy that there is. And frankly, that probably still is the best mitigation strategy, but we also are 6 months in and people have to work. We are not in a country where we've decided to pay everyone to stay home. So it's, we have to understand our privilege when we're saying go home and stay home. So we have started to try to refine our messaging to our audience about behavior when you have to go out, how to choose when you're going out, when you're not going out, understanding that not everyone is in the same situation. If I lived in an apartment by myself, staying home for 6 months might be pretty intolerable. Staying home with an 8-month-old is also pretty intolerable. Can you talk to us about just, understanding that people are going to go out sometimes. People are enjoying the restaurant district in Fayetteville and, having drinks outside. Some people are having to go to work. Besides masking, how can we be best protecting ourselves in those instances that we are leaving home?
Yeah, I always tell people, think about what your report to the contact tracing team would look like if you got sick tomorrow. So would you feel good listing all the places you had been and all the people that you had been within 6 feet of? So I think if you think about it from that frame of reference and, you do your best to limit contact, that's all anybody can really ask. And we all have things that must be done. It is not possible to put things off forever. There are vehicles that have to be registered at the DMV. There are things that have to be done. And so that is what it is. But I think as long as we're all sort of taking seriously the sort of factors that make us both more at risk ourselves, but that make us more likely to also infect someone else if we are unknowingly pre-symptomatic or potentially asymptomatic. So limiting your time, having short visits to places that you need to go to, sort of plan ahead so you can expedite trips out, be efficient in your use of time, have a sort of, there was a lot of talk about sort of quarantines and small groups of people that you interacted with, but there is a thing about interacting with the same person multiple times is less of a risk than interacting with a broad array of people just once. So understanding sort of your exposure circles and having really frank conversations with the people that you are spending time with about what their contact tracing list would look like. So, if you're going to see your, sister and brother-in-law, or you're going to see your parents, understanding what their sort of risk tolerance and perspective is an important thing. And, it's not going anywhere anytime soon. So I think it's important at this stage and phase to recognize that whatever we do now is just the next normal and will likely change again. And it's a matter of sort of getting to a place that we can sustain for, potentially quite a long time.
I've been talking to friends a bit about how COVID has really brought the idea of consent and sort of like honesty with your friend circle to a whole new level. There was a lot of sort of PSA work done in the 90s about talking to your sexual partner about your previous sexual encounters, and talking about consent and making sure that everybody was well educated on the choices that they were making. And this really blows that out of the water into sort of like, I would like to see you for a coffee. Can you tell me the last 48 hours of exposures you've had? And how that's sort of like really taking friendships to a whole new level.
Yeah.
How do you have that conversation with people who may not be as open to that sort of like radical transparency? Or how do I have that conversation with my weird, uncle that I'm going to have to go to dinner with at some point?
I think just like that, you just say, this is uncomfortable. This is not a conversation I ever expected to need to have. If we're going to see one another, I need to ask you about this. And then they'll respond however they'll respond, and you'll make a choice and they'll make a choice, and there it goes. But
yeah,
I think the worst thing to do would be to ignore it, not have the conversation, and then have one or the other party have really hard feelings if everyone does in the end up getting sick through whatever exposure chain. I mean, I think it's, in epidemiology, we talk about things being endemic, meaning like community transmission is widespread. So at this point, the source, I think people have to be really careful to not create some sort of blame of you gave me this illness, and certainly no one's doing anything intentionally or out to harm anybody. It is a community spread, communicable disease. So at this point, we're all, doing what we can. And I think it's about that. It's about giving people the benefit of the doubt and being flexible and assuming good intentions. And then, if you get sick, taking good care of yourself and making sure that you're not knowingly exposing other people, while you are symptomatic and or testing positive.
And so, the last couple days in Arkansas, we've seen not today and the day before, but the days before that, we had been seeing some trending down, like 3 or 4 days of trending down in the case numbers. And, I am on social media. I'm watching my friends get cautiously optimistic when we have a weekend of low numbers. I have some theories about testing numbers on the weekends and how they may not be as high as testing numbers on the weekdays because it's a weekend, but nonetheless, as we see a couple days of numbers going down and then we see numbers coming back up, what daily count really should we be looking at as a target for when we start to get cautiously optimistic about what progress actually look like?
Yeah, I mean, raw case numbers means a little. So without sort of the denominator, without knowing how many people were tested and knowing sort of positivity rate of the pool of people that were tested, it's not super helpful information. I mean, it certainly tells you that there are more or fewer cases around, but only as a percentage of people tested is that particularly meaningful. And you're exactly right that the number of tests done vary, day to day and certainly week to week. That being said, it's also really important not to sort of over smooth the curve by reporting, which has been in the governor's report and I think is somewhat misleading, the case positivity percentage since the very beginning of tracking, which was in March. So, it's important to look at things, hyper-locally, so by county, by city, by MSA. And it's also important to look at sort of the trailing 7 days or the trailing 14 days. So what does it look like in the relatively recent past and also in your very specific place, as opposed to what does the whole state look like since March? Because obviously things have changed.
So is the daily case count is just one number we get every day. Would it be more useful for us if we're really trying to get a read on what's going on to be looking at the hospitalization rate or the death rate or like percent positivity? Which of those numbers do you look at most?
Hospital census numbers, which are not as readily available as people might think. So it's not something that hospitals necessarily are constantly reporting what their daily census is. They measure that certainly internally, but there's not a sort of daily ticker at the state level of how many people are hospitalized in what hospital. They've made significant progress through the public health school in Little Rock and UAMS to get more specific about hospitalizations. But, the important part is regardless of how many people are infected, it's how many people are really ill and is there a capacity to take care of people who do get really sick. And so, sort of hearkening back to rhetoric around flattening the curve, the point of that is, are a small percentage of people who are infected then get really sick? And is there the capacity to take care of people who do get really sick? So obviously, a small percentage of a big number is a big number. A small percentage of a small number is a small number. So when we have lots of community transmission and lots of positive cases, so that case rate, that sort of daily number of new positive cases is meaningful in so much as you can assume that about 10 to 15% of those people will be ill enough to need hospitalization or at least, direct medical care. And so when you look at that as sort of the cumulative average. And the other thing to say about people who do ultimately need to be hospitalized is those hospitalizations are more than double the number of days of the average hospitalization in the US. So the average hospitalization in the US is around 5 days, and it varies a lot state to state and locality to locality. The average coronavirus COVID admission is more like 14 days. And so people are not sort of being admitted and then being discharged the next day. They're there for quite a while. And so what that leads to is sort of a backlog or a backup of people who are still admitted who were sick 2 weeks ago, plus all the new people.
Can we talk about hospital census let's just say Northwest Arkansas, because that's where we are. Have we at any point during this maxed out our ICU beds, or how do we stand currently? Or is that information that you even know?
Yeah, so the COO of Washington Regional put out a public facing letter not long ago saying that their resources are running low. And so the thing to sort of know is that it's not just beds in a hospital. It's beds in a hospital that are capable of providing that particular kind of care. And it's also human capital. So it's also the doctors and nurses to take care of those people. And at this point, we haven't made like lots of new pulmonologists or lots of new ICU nurses in the past 6 months. And so those folks are tired, they're stressed, ICU nurses are used to taking care of people who mostly get better. They're not quite so used to having so many people who don't make it out of the unit. And that's a very emotionally taxing thing to have a big jump and then sort of percentage or proportion of your patients who don't make it. And so I think, more than necessarily just the like number of beds, we have to think broadly about healthcare resources and healthcare personnel.
You make a really good point in that one of the most limited resources we have is the healthcare professionals themselves, because they're just human and they are just limited and they can only do as much as any human can. Washington Regional actually has come out with several promotional is probably not the right word, but sort of public service videos that are nurses talking about this experience and talking about their time and how tired they are, and basically asking the community to do better. I think that those are really brilliant and very effective. I'm wondering, as a doctor yourself, are there messages that you would like organizations like ours to be saying to people, so that, communicating on behalf of your people, as it were?
Well, I'm the academic kind of doctor. I'm a nurse through and through. I still carry a license. I still am a practicing nurse. And, I think we like to think of ourselves as being invincible, because otherwise it's really hard to get up and go to work if that's what you've got to do that day, if you don't think that way. But to your point, nurses and doctors and the people who make the food in the hospital and the janitors who are cleaning the rooms are all just people who also have families that they're worried about taking the virus home to. That's a whole different level of anxiety. People have been separated from their children for months on end. There are all kinds of things that the healthcare providers and employees of the hospitals have had to do to limit the risk to their own, family units. And so I think it's incumbent upon us all, I consider myself the non-practicing side at the moment. So, to just really think about those people when it's like, oh, I desperately need to go to my girlfriend's birthday party with 35 other people who are also tired of all this and just want to go out and have a good time. Okay, but if me going out for cocktails means that my nursing colleague doesn't get to see her kid, that's a pretty cavalier sort of trade-off. So I think, it is a tiresome thing. People are tired. People are done with the limitations on their interactions and their lifestyles. And also, it's a lot harder for some of us than others. And I think those of us, myself included, who have the choice to stay home more should take that seriously.
Anecdotally, I can say that I have an 8-month-old. She was born on New Year's Eve. So her grandparents, who are both, my dad's a doctor and my mother's a nurse, haven't seen her since March. So they've missed the whole thing at this point. They've missed the infancy and all of the good, she's standing up and chomping on stuff, and she's about to just get up and walk away now. So it is, there are people who can't see the people they love because they are afraid of bringing this stuff home. And I think that as tired as we all are, it is good to be reminded that there are individuals who are looking at this thing every day and making the choice to stay apart from people that they love and to keep everybody else safe. So that, I just felt like I had to throw that in there for the audience to be reminded that, yes, we do all want to hang out, but people want to see their grandparents, people want to see their kids. So before we move to audience questions, because we do have a few, I'd like to just briefly talk about vaccines. And I don't want to go down too big a vaccines rabbit hole, but I have noticed a trend of memes on social media talking about a lot more people than I would expect to see saying that they won't take it once it's developed. And my question, not really about the efficacy of first round vaccines or vaccine testing or vaccines in general, but what does it mean for those who do want to take a vaccine? What does it mean if nobody else takes it? How does that affect whether it's a useful endeavor at all?
Yeah, so vaccines, like anything else, have an individual decision-making process and level of effect, and then sort of a population level process and effect. So I think on an individual level, in theory, an effective vaccine should mean that you have immunity and wouldn't be infected, or so if sort of more along the lines of a typical seasonal flu vaccine, the strain is different, then you would have sort of a less severe case, less chance of needing to be hospitalized, an imperfect vaccine might not work perfectly if you have the vaccine. It for sure won't work at all if you don't have it. So, I think that's about as simplistic as you can get. On the population level, certainly the concept of having herd immunity, the concept of enough people being immune that it essentially breaks transmission chains is a lovely concept, and we're really far from that. So there are diseases that have been totally eradicated by effective vaccine programs, smallpox being the sort of cardinal example of that. But that takes a level of vaccination that is really hard to attain, even when it's a long-standing effective vaccine, and probably very unlikely with a new vaccine that, even if wildly effective, still has to go through a production cycle to be produced at a level that has, population-wide uptake.
So I've heard, this entire time there's been a real problem with inconsistent information coming from literally all the places, top down especially. The administration currently seems to believe that there will be a vaccine available in the fall. Dr. Fauci has said he's cautiously optimistic for end of year. In doctor circles, in the academic circle, what are realistic expectations for a publicly available vaccine for those of us who are not even particularly high risk, but who would like one?
I think anybody who tells you they have an answer for that question is probably not telling the truth. I don't think anybody knows. There has to be something that's effective in trials. There are lots of vaccines in trials. Several of them advance to level 3 trials that are like human trials happening in hospital settings for hospital healthcare workers who are at high risk. I'm familiar with several of those. What I would say is they are happening on foreshortened timelines, but even if, they are shown to be effective, again, you have the production timeline. And I think we're not used to making large scale vaccine on short notice. We have a hard time keeping up with seasonal flu vaccine demand in the US. And, I just don't anticipate it being radically different, because there are so many things in the process that have to happen in order for that to really happen. That said, this is affecting the economy. This is affecting, each of us individually. I would like to think that sort of all the available resources would be put to use to make an effective vaccine as available as possible, as quickly as possible. I certainly don't have any idea what a realistic timeline for that is.
Well, thank you for the honest answer, at least. It's an answer, right? We don't know the answer is an answer. So school started back this week. Can you tell us what you think what that might mean for us looking at caseload over the next coming weeks with the university specifically coming back online?
Yeah. I think we should expect a spike in cases. I think it would be irresponsible not to expect that. I do want to say that, the state has done a pretty good job of trying to create surge capacity. So as much as healthcare resources are limited, they have done a great job and put a lot of effort over the past few months into regionalization and being able to shift healthcare resources to meet needs as they arise. And I think, it's not easy, and it's not something that's been done a lot before this. So you don't really know how something's going to work the first time you're using it. But there has been a lot of effort to plan for and accommodate a spike in cases associated with both public schools going back to school and the university coming back online. The downside of that is if that spike overwhelms the system, then we're likely to go back to a much more shut down mode. So we'll see is really the only answer. What it does mean, though, for people who are high risk, who are vulnerable and at risk of severe health complications and or death. So people who are older, people who are immune compromised, who have underlying health conditions, really do need to individually be even more careful, because you have to anticipate that there's more community transmission with kids back in school and the university back in school. So it then becomes incumbent upon those of us who are ourselves at high risk to stay home even more and avoid contact even more.
For kids that have gone back to school this week, like under 10, what are some things parents can be telling their children, maybe some language they can be using to explain to their children the situation, and some practices that they can put in place that might help with mitigation?
Kids inherently understand transmission. All kids across all cultures I've ever been exposed to have some version of a game that's like cooties, like, you're icky, gonna make me icky. We typically try to really get them not to play those games and talk about how, terrible and avoiding bullying and all of those things. But children understand more than you think they do, is all I'm saying. So they have their own version of understanding. Speak to their listening as much as you can. Masks are actually not a terribly difficult thing for most little kids. They adapt. Their children are more adaptable than adults. They kind of are like, well, this is just what we're doing now. And so, I think, at least from what I've heard so far, the schools have had pretty good luck with kids keeping masks on, and the kids really want to be in school. And they've kind of gotten the message that in order to get to go to school, they have to wear their mask. And so I think, they don't necessarily have to understand every detail of what's happening to know what to do. So developmentally appropriate language and, focused on behavior and sort of the task at hand. And then there's the rest of their life for the sort of meaning making part of them understanding what all of this has meant for their development and their education and all of those things. But for right now, I think just super simplistic, let them tell you what they understand or don't. and really focused on washing your hands, not touching your face, and wearing your mask.
Again, anecdotally, I have a 3-year-old who it is now easier to get a mask on her than it is to get her socks on her. So I feel like we really won that one. And some of the things and I've learned the more I let her wear it, the more we go out with her in the mask, she'll tell me if it falls off now, right? And she'll say, my mask's not on. You need to help me with my mask. And that's been really refreshing because, of course, I know a lot of parents are feeling really guilty about how limited the world size of our kids has been, and that it's terrible to keep a 3-year-old or a 5-year-old or a 10-year-old or a 17-year-old locked in the house for half a year. So yeah, I think mask wearing, I feel like mask wearing is just the thing to say to everybody all the time.
Encourage people those of us who have all this long life of experience to not project that onto a child who doesn't know any different. So the 3-year-old probably doesn't know that she's supposed to be upset that she's been at home. Like a 17-year-old definitely knows, but at the same time, let them be as adaptable as they are. Don't sort of impose adult thought process onto a child that developmentally is still in a very concrete state and, doesn't have the experience set to know that they're supposed to be at, a play date every day or whatever.
That's very practical advice. Actually, that's really good. We have an audience question, which is, can we go over the common symptoms again? Just concretely.
But unfortunately, the common symptoms are the common symptoms of all kinds of things. So probably the hallmark symptom is fever. If you have a fever, that's notable. And I think, the adoption of taking people's temperature is mostly overblown in so much as they're surface temperatures, they're not really body temperatures. But I do think it's created an awareness around fever that's important. So fever, chills, new cough, new runny nose. It's particularly frustrating because it's ragweed season in Arkansas, and those of us who are seasonal allergy sufferers are entering the prime part of fall allergy season. So, I think loss of smell and taste have sort of come along as more specific symptoms. Not everybody has those symptoms who has the virus or gets COVID is the disease caused by coronavirus. I feel like I'm sort of using them interchangeably, but not everybody has a loss of smell or taste, but if you do have a loss of smell or taste, that should raise your level of suspicion greatly.
This is a kind of pedestrian question, but I think worth going over. When coronavirus, when this outbreak began and COVID-19 we were all learning about it, there was an emphasis on having a dry cough. And I found myself often Googling, what's the difference between a dry cough and any other kind of cough? Like, what is that? What am I looking for in a dry cough?
So as gross as it is, it's just that you're not coughing anything up. So a productive cough is the opposite of a dry cough. Gross, right? But essentially that when you cough, you're coughing up sputum, you're coughing up discharge. The dry cough thing is a tricky one because, again, allergies, asthma all come with dry coughs. It's asthma and allergy season. But I think, in combination, certainly with fever, new onset cough, new onset fever together, is a pretty suspicious profile. And if you can't taste anything either, need to be tested and quarantined.
So the CDC they amended their testing recommendation this week.
I'm glad you brought that up. Yeah. Frustrating. I feel like it's like the 2.0 version of the mask conversation. So unfortunately, we have shortages of testing supplies and reagents again. And so there was a guideline around testing of asymptomatic people saying don't over-test, basically. Don't test asymptomatic people if they, even if they've had a potential exposure. Well, okay, what they were trying to say, I think, was we don't have enough testing supplies to do population level prevalence testing. So you don't need to test an entire school full of children before you send them back to school. The test sensitivity is still low enough that a negative result is not all that helpful. So certainly finding a positive is an important thing, and having someone who's positive not come to school. But if you have to test 500 kids who are all asymptomatic to rule out 3 positive cases, I think what they're trying to say is that's not a good use of testing capacity at the moment. There may come a time where we're all tested routinely once a week or something. I don't know. But I think that's where they were going with that. I wish they had just been clearer about it, but I think there's an effort to not make people anxious that there isn't enough testing. There's enough testing if we're testing sick people. There's not enough testing if we're repeatedly and routinely testing people who are not sick. So I think
I appreciate you putting in the context of Mask 2.0 because in the beginning, and this is, we because we were jumping into mask production, we really spent a lot of time thinking about masks back in March. And what we found, and what, I can't say it's fact, but what I seem to have seen is that the recommendation to not wear masks by the CDC in the beginning was not based on the efficacy or use value of masks, but was rather based on a shortage of masks.
Yeah, they didn't want people to go out and buy up all the masks when doctors and nurses didn't have enough masks. I mean, it's that simple. And it is true that the focus initially was on, will a mask protect me from becoming infected, rather than source control, because there was not a clear understanding, especially in the early days, of pre-symptomatic or asymptomatic community spread. So there was sort of the thought that, like other illnesses, there wasn't much of a pre-symptomatic phase. We now know that there's as much of a 2-week window of pre-symptomatic infectiousness or potential for infection. And so, unfortunately, I think it could have been clearer. I think, but there's a lot of politics that goes into how those statements are worded, and there are a lot of agendas outside of just the public health one that have to be considered in writing those things. And unfortunately, the consequence was that, when then the recommendations shifted and it became more about source control, and we understood that there was a pre-symptomatic, if not asymptomatic also, part of the infectious pathway or chain, it was hard for people to believe that, that shift was meaningful and that they should wear masks. Honestly, I feel like had the messaging been clearer on the front end, mandates might not have been necessary. Statewide mandates became necessary because there were mixed messages and people didn't voluntarily buy into wearing masks. And so then, we got to the point in terms of the case numbers that the mandate became useful. And I will say that in Arkansas, since the statewide mandate happened, the numbers have leveled off. Mm-hmm. So they've not gone down, but they're also not going up precipitously as they were prior to the mask mandate.
Another audience question, and I know you've got a hard stop, so we're going to do 2 more questions and then we're all out of here. For the holiday season, do you think that there is a way to safely visit non-household family? For instance, if we quarantine for 2 weeks before Thanksgiving, are we relatively safe to visit family members over 60?
So I think the key to that is relatively. And the other thing to be really careful about is I realize that people have made all kinds of different choices for all kinds of different reasons about this, but commercial air travel is a huge exposure. So if you're going to quarantine for 2 weeks, then you also need to drive in a car and make as few stops as possible to go wherever you're going. There's been a lot of case reports now of people who were quite careful, but then got on a plane to go to wherever and, maybe even made it all the way through their trip and flew back before they started having symptoms. Well, that makes it really hard to track down, A, where they picked up the virus in the first place, but B, then how many people they may have exposed while they were traveling.
So my final question, and this is just a really pragmatic one. Say somebody at my office has COVID-19, and we find out. How soon is a test useful? How early is too early to test?
So this also has a variety of answers based on testing availability. So how I'll answer it instead is, when do you for sure need a test? So if you have been within 6 feet for more than 15 minutes with this person, you will need to be tested, and you should self-isolate as soon as you know that that's a possibility. And then you should get tested probably around 7 days post-exposure, meaning that the majority of people who will test positive, more than 50% of people who will test positive post-exposure will test positive by 7 days. There's then this sort of 7 more days of trailing time where, the possibility of additional positives can happen. So if it were me, I would self-isolate and wait 7 days, or get tested if I develop symptoms. So if you develop symptoms 3 days out, get tested. If you don't have symptoms 7 days in, but you, for either your employer's policy or for your own sanity or for whatever reason, need to know and don't feel comfortable just continuing your self-isolation for 7 more days. Because the other option is just self-isolate for 14 days. And if you don't get any symptoms in 14 days post-exposure and you haven't had any new exposures, you can feel pretty good about that. It's really hard not to have any new exposures. I mean, you really have to self-isolate. And I think because this has gone on for so long, people think being sort of isolated is isolated, and it's not. Self-isolation really means you haven't been in contact with anybody else.
Right, because and it's worth reminding people here at the end that even if you're in contact with one person and that person's been in contact with other people, you've also been in contact with all those other people. So self-isolating really is isolating.
It really is. Which is why it's good that we have access to testing and that you can be tested, but essentially it's this rolling exposure window, right? And so your negative test a positive test is a positive test. It's that false positives are not a thing for an RNA, a PCR test that's looking for viral RNA. You don't have to worry about a false positive, but there's a relatively high false negative rate. And so if you've had a negative test, but then 2 days later you get symptoms, it's probably still COVID, and you probably just need to get tested again.
I have I have likened it. It reminds me of pregnancy tests. A positive pregnancy test is you're pregnant, but you can be pretty pregnant and have a negative pregnancy test. So that's what I tell my friends, to think of it that way.
Well, I think I think I would just be on the lookout for symptoms regardless, and take any symptom seriously. So, as hard as it is, especially right now in allergy season, if you get a fever, you need to take that seriously and sort of presume that it's coronavirus until proven otherwise, rather than, oh, let's see how I feel in a couple of days, because in that couple of days, you may have exposed all kinds of people.
Well, Dr. Osborne, do you have anything you want to add on the tail end to the audience, or?
No, just to say that I'm right there with everybody else. I'm over it and ready to be out and about in the world. I used to travel about 15 days a month, and I haven't been anywhere since New Year's Eve. So, I've had a couple of quick, truly self-contained car trips. I never knew it would be as apropos as it ended up being, but I bought a Sprinter van, like a modified Sprinter van, a couple of years ago. And so, having your own facilities and refrigerator, it turns out, can be a really good thing.
Yeah. Well, thank you so much for joining us. And I have more questions, but maybe we'll do another one in a couple weeks. Maybe we'll do another one when flu season gets going.
Yeah, so I will address that just really quick. If you are at all open to it, get a flu shot early, like now, and maybe again in February, because ruling out flu is one of the differential diagnoses. So if you have a fever and symptoms, part of what has to happen is deciding that you don't have the flu. So you're less likely, of course, to get symptoms at all if you've had vaccination for flu. And it helps the healthcare workers differentiate.
Get a flu shot tomorrow. Go do it. All right. Thank you so much, Dr. Osborne. Have a lovely evening. And we'll be posting this on YouTube within a couple days. So we'll share it again. And again, thank you all for joining us at the Arkansas Arts and Fashion Forum. We're all in it together. Take care and do the best you can. Thank you. Bye-bye.